Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 82. Time. In obstetrics, we're just a teeny tiny bit obsessed with time. Time, the passage of time, is very important because we're a very acute specialty. One of the first things you learn when you go into O&G and do a job, or if you're a midwife for that matter, is that when you're documenting things, you not only have to put the date that you're seeing the woman, but the time. And when I say the time, I don't mean that you're going to put down, for example, as I'm recording this, it's just after 5 o'clock. I mean that you're going to write down that it's 17:13. Because the preciseness of the time is very important. So every time I walk into a room, every time I see a woman in labour, every time I do anything, I have to document the time, the date, who I am, and sign and print my name. I've been thinking a bit about time in the last few weeks, partly because we're at that point in the year where the clocks change. A clock change shift at this time of year, when the clocks go back, mean that all the midwives and doctors on that shift work an extra hour. And I tweeted recently to thank all those in the NHS who were working an extra hour. And one of the responses I got as a result of my tweet was, yeah, but you all get paid for that hour. Surely you do. And it suddenly made me realise, actually, no, we don't. We're not really paid in hours. Certainly doctors are not paid in hours. Midwives, it just counts as another shift. And if the shifts are normally 12 and a half hours and this one happens to be 13 and a half, well, that's your tough luck, actually. So no, we don't all get paid for it. But putting payment aside, clock change is complex. It's complicated. How do you document how you're caring for a woman in labour when 1 minute it's one time and the next minute it's the next? It can become very confusing. Not only that, but everything has to change. Every piece of machinery that has a time on it has to be adjusted. My normal labour ward is a Monday, and I came in on the Monday after the clock change on the Sunday to find at least half the fetal heartbeat tracings were still saying the wrong time. They still hadn't been adjusted for the clock change. They were printing out things saying clock mismatch. And obviously we knew that, and obviously we can document that, and we can be aware of that. But if you then go back and look at a case at a future point, maybe years down the line, remembering there was that clock change and what is British summertime and what was GMT, and therefore what happened when, can be very confusing. Does it matter an hour here and there? Or even a minute here and there? Well, in maternity, in intrapartum care, it absolutely does. There are points in labour when every minute makes a difference. Every minute counts. That might be when a woman is bleeding excessively, but it also is certainly true of how the baby is. So today I'm going to talk a bit about time and the impact of time and why we have to be so precise with our timings in maternity care. I'm going to start with an emergency situation. It's an emergency. The baby's heartbeat has dropped, which we might call a bradycardia, a slow heartbeat, or in my unit, we'll call it acute hypoxia. We're worried about this baby. It might be for some correctable reason. Maybe the woman's blood pressure's dropped or she's laying flat on her back. It might be the result of an epidural top-up. But it might be the result of an acute event. Something going badly wrong, such as the womb rupturing, a placental abruption where the placenta separates prematurely, or the umbilical cord prolapsing, the umbilical cord coming down into the vagina and having the pressure of the head upon it, compressing it. In this situation, the baby's well-being can change rapidly. When we look at how a baby is doing, we tend to look at its pH, how acidic is its cord blood. A normal pH would be 7.25 to 7.35. If a baby is short of oxygen and it's going into anaerobic metabolism, a bit like when you do a workout at the gym and your muscles start to burn, then the pH drops and becomes acidic. And we know that above 7.0 pH, it's very unlikely that the baby will sustain any damage. Whereas if it's below that pH, there is a possibility. Not definite, but a higher chance, and we'll need to institute treatment of that baby to try and prevent damage. Why am I talking about pH? Let's go back to the situation I mentioned. The baby's heartbeat has dropped. We've got an acute event. Fetal pH drops at a rate of 0.01 per minute. That means maybe not very much, but if you go back to what I was saying about a normal pH being 7.25 and above, and the possibility of damage being higher if the pH is below 7.0, you've got 25 minutes of that acute event before that baby is in danger. Bear in mind, if the baby wasn't in a good state to start off with before that acute event, so the baby was already a bit stressed, maybe the pH was already 7.1, you've got even less time. So it's generally accepted that when you have an acute event, a bradycardia or acute hypoxia, we work by the rule of 3, 6, 9 and 12. That means within 3 minutes of that prolonged drop in the baby's heart rate, the midwife in the room should be calling for help. By 6 minutes, we should have some idea of what might be causing this. Was it simply an epidural top-up that a change in position or giving the woman something to improve her blood pressure might help? Or is this one of those acute events I mentioned? We might need to examine the woman and feel her abdomen to know what is happening. So we should be doing that by 6 minutes. If we haven't been able to reverse the cause, or we've diagnosed that there is one of those major complications, by 9 minutes we should be moving to theatre or taking steps to deliver the baby, unless it's a reversible cause, of course. So if there's no recovery by 9 minutes, we should be thinking about a caesarean birth or assisted vaginal birth if the woman is fully dilated. Of course, we can go to theatre, and if it all corrects, we can come back. But by 12 minutes, we should be in theatre, preparing to give an anaesthetic or already giving an anaesthetic to get this baby out. So minutes count. And this one would count as a category 1 caesarean section or a category 1 delivery, where there's an immediate threat to the life of the baby or the mother. I talked about this a little bit in my episode 39, caesarean rates. We would expect what we call the decision to delivery interval to be within 30 minutes. So within half an hour for that baby to be out. So in that time, we've got to have diagnosed if there's a problem, moved to theatre, given an anaesthetic, explain to the woman what's going on, call the paediatricians and get that baby born. That's an extreme example of where timing is important. But there are other situations in which it's equally very important. Take shoulder dystocia, when the baby's shoulder gets stuck behind the woman's pubic bone, and we have to do additional manoeuvres to deliver the baby. We'll document and write down what time was the head born, what time did we do what manoeuvres, and what time was the body actually born. What was the delay between the birth of the head and the birth of the whole baby? And it's the same when we're doing a caesarean. We usually have a support worker or runner in theatre who will meticulously document what time was what we call knife to skin when we made the incision, what time was knife to the uterus, when did we cut open the womb, and when was the baby born. And usually at caesarean, it might only be a minute from when we cut into the womb to when the baby's born. But if we have difficulty delivering that baby, if we have difficulty because the head is deeply impacted or the baby's in an awkward position that's difficult to get out, again, every minute counts. Every minute from when the womb is opened to when the baby is born, potentially that baby's pH is dropping. Potentially that baby is facing an insult. And again, if you start with a baby that's not in good condition and that's why you went to theatre in the first place, it's really critical, that length of time. And the longer it goes on, the more we anticipate that baby may have problems. So if we have some difficulty and there seems like there's a delay, we will call for a senior paediatrician to be present because we know that that baby is more likely to need help getting started with its breathing. Timing is just as critical in other areas. For example, the Breech Birth Network have analysed vaginal breech birth, physiological breech birth, upright birth. And they found that in the majority of cases, from when the baby's buttocks are born, so-called rumping, to when the whole baby is out, should happen within 7 minutes. And if there was delay at any point, if the baby wasn't progressively delivering, with more of the baby appearing every few seconds, that we needed to intervene because there was delay to improve the outcome of the baby. 7 minutes, that's hardly anything. We need to recognise and anticipate, is this birth going to plan? Is this going how we expected? And if not, we need to intervene quickly within that 7 minutes to try and help that baby achieve a safe birth. And again, it isn't that after that 7 minutes, there's a cut-off and there's definitely going to be problems. But from analysing those births, they discovered that if it was longer than 7 minutes, there was more chance of that baby needing help and support in the neonatal period. Often the decisions we take influence the timing as well. For example, if an assisted vaginal birth is required, there's good research evidence that shows if we can do it in the labour room, in the room where the woman was labouring and planning to give birth, that birth will be quicker from the time we take the decision to when the baby arrives. So if we have an acute event and the baby can be born vaginally and we can perform an assisted vaginal birth, we will often choose to do it in the labour room because the baby will be born about 15 to 20 minutes after we've taken the decision, on average, if we do it in the room. Of course, there are situations in which it's more beneficial to go to theatre, but when taking that decision, we have to be aware that there also will be some delay. Unless it's a very urgent Category 1 delivery, the evidence shows that just that decision to go to theatre, requiring more checks, anaesthetic input, and the physical move to a theatre, whether that's adjacent to your maternity ward or not, will cause delay. So that women that go to theatre for an assisted vaginal birth usually deliver with a decision to delivery interval of 40 to 50 minutes, in contrast to the 15 to 20 minutes in the room. Of course, some of that will be because we've chosen to go to theatre because the baby's head was a bit higher in the pelvis and we're anticipating a bit more difficult delivery. And therefore, going to theatre was actually not necessarily the only delaying factor. Perhaps we needed to rotate the baby's head as well as bring it down lower. But this delay means that when I have junior colleagues who are learning to get more experienced at which assisted vaginal births they can perform in the room and which ones need to go to theatre, even when they're a bit anxious and hesitant, I need to encourage them to learn the skills to be able to do it in the birthing room so that they can do it quickly in an emergency situation and feel confident that they know they can get that baby out safely without recourse to going to theatre. Not going to theatre doesn't mean no pain relief. Some women obviously will already have an epidural, but if they don't, we can use a pudendal local anaesthetic block, which is surprisingly effective, blocking the pudendal nerve that supplies the area of the perineum and providing good pain relief very rapidly in those emergency situations. Time also becomes really important during an assisted vaginal birth. There's a finite amount of time that we should have our suction cup or ventouse on top of the baby's head. Ideally, we don't want it to be more than 15 or 20 minutes or so. We used to have clocks in all our delivery rooms. It was helpful to me. I could look up at the clock and see exactly what time it was when I applied my ventouse, my suction cup, and I would know with each pull whether the baby was coming down, but also how much time was passing. 15 to 20 minutes may seem like a long time, but actually, if you're only having a contraction every 2 or 3 minutes, that may not give you very many contractions through which you can successfully assist the birth of the baby. Of course, you can leave the cup on a bit longer if the baby's making progress and you know that birth is going to be imminent. But you know that the longer you leave it on, the more chance of possible complications for the baby, such as bruising, sometimes described as a cephalohematoma. Timing isn't just important for the baby. Timing in minutes is also important for the woman. Let's think briefly about the birth of the placenta. Usually the placenta will separate. You'll see signs of separation, and the placenta will come away within about half an hour of the birth. So we record the time the baby is born, and then we're waiting for the birth of the placenta, looking for signs of separation. The woman may have had what we call an active third stage, where she's had an injection to help that placenta separate. If the placenta hasn't separated and come away by 30 minutes, between 30 minutes, so half an hour and an hour, we need to be taking steps to assess what is going on. Has the placenta not separated? Is the placenta perhaps trapped in the cervix, in the neck of the womb? Are we going to need to go to theatre? Is the woman bleeding? If that placenta hasn't been birthed by an hour, then we need to be going to theatre, because the longer we wait and the longer we delay, the more the chance of that woman bleeding an excessive amount of blood. So this is a situation in which timing is of great importance to maternal well-being. The longer we wait, the higher the chance of her losing a large amount of blood, possibly delaying her recovery from the birth, perhaps affecting her milk production, maybe needing a blood transfusion and a longer stay in hospital. These days, we don't have clocks in our birth rooms. Part of the rationale for that was it wasn't great for women to have to be staring at the time during their labour, feeling like they were clock watching. And time itself is a very interesting construct. I'm actually reading a book at the moment about time, and that actually the fact that time is actually an idea, time is something that really came into greater effect in the 18th century with the advent of industrialisation, moves from a much more agricultural way of life to time-banded life in a city and the introduction of far more clocks. So I can see why having a clock in the delivery room can be unhelpful. We've been through all sorts of clocks on our delivery suite, and that sounds a little bit odd, but when we had the bog standard battery operated clocks, we used to have a major problem that the time in different rooms, or the time in the room and outside in the corridor, would say different things. And then the CTG might say something different again. And we would find that we would go around to theatre and suddenly it would be 10 or 15 minutes later, just because there was a different time on that clock as well. So the accuracy of the clocks, when timing and minutes are so important, is essential. We then switched to radio controlled clocks, and the idea was that they would all be synchronized, and that would reduce this problem of us finding disparate times and confusion when we were looking at incidents. For some reason, that never seemed to work very well. But now we do seem to actually have a system that does work, in that we have an LED clock that's coordinated throughout the unit. So it says the same whether you're on the postnatal ward, the labour ward, the antenatal ward, or the antenatal clinic. But as I mentioned at the beginning, we still have the issue of machinery, whether that be syringe drivers to deliver drugs, CTG to monitor babies' heartbeats, pulse and blood pressure machines that need manual checking and making sure that they are synchronised and up to date with clock changes. So although it sounds a little bit like we can be time obsessed, one of the key things in maternity, therefore, when there's any acute emergency, is someone takes up the role of scribe. Someone will actively be writing down what time it is at each intervention, which staff came to the emergency, and exactly what was going on, so that when we look back, we've got an accurate record. Because otherwise our timings can be all over the place, and the timings are critical. The timings can have a huge impact on outcome. I've always enjoyed that about obstetrics. Of course, it's scary. You know that your decision and the action you take and how swiftly you take it and how you work as a team to come together and deliver that swift action is unbelievably important. But it also means where you can swiftly go into theatre and have a woman and her baby safe within maybe 15 minutes. You've got an incredible sense of achievement. So where does this time situation leave us? in terms of a zesty bit, the essence, the bit I want you to remember? I think it is that if you're a member of staff in maternity and you know something is time critical and you are looking after a woman in that time critical moment, it does not mean that everything has to be chaotic and stressful and horrible for that woman. One of you, preferably the midwife looking after that woman, can look that woman in the eye and say, we're worried about your baby. We're taking this action. We can manage this situation, but we need to move quickly. Don't worry, everyone is here to look after you. We're going to go to theatre because we don't know how this is going to turn out. And it may well be that when we get to theatre, everything will settle down and we'll be able to come back to this room. But we can't take any chances. It's important that we go, and we go now, and then change our minds if it's no longer necessary. I think we have to be firm, but we have to be reassuring. We have to explain the rush and that this is time critical and we don't have time. But we can also reassure her by keeping calm. One of my colleagues, looking at human factors, talks about being in the spotlight, being on stage. If you imagine when you're caring for that woman, it's like you're on stage. You're in the spotlight. She's looking at you. If you are calm in the face of this urgent situation, then she will be calm too, because she will have confidence that you're not out of your depth, that you do know what you're doing, and that everything will go well. And that although an unexpected, frightening situation has arisen, you are calmly dealing with it, and she will have confidence in you and the team with you. If you're a pregnant woman listening to this, understand, I guess, what I'm saying about how rapidly we might need to make a decision about your care. And it may be that this could not have been anticipated. And don't be confused when and if we change our minds. I know it can be really difficult to trust staff when they rush you off to theatre, telling you your baby's in danger, and then the next minute they're saying, in theatre, oh, it's all settled now, everything is fine, we can go back to the room. We have to do that. We have to do it as a precaution for those times when it isn't okay and we do need to proceed. And that's why we will be hurrying you. But it's okay to ask your midwife questions while the team are rushing around you, as long as we're keeping things moving. So we're talking to you while we're moving through the corridor, or we're talking to you whilst we're preparing you for theatre. And in those situations where there is an acute event and we need to get your baby out, I can tell you we can do it within 15 to 30 minutes. That's our goal, and we achieve it. So if that unexpected event arises, put your trust in us, because the faster we move in those rare situations, the better for your baby. I do hope you've enjoyed listening to this episode of the theobspod. Feel free to contact me on Twitter at FWmaternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.